Hello everyone, welcome to Module 2. In Module 2 we'll be talking about HIV testing. This is not a core pharmacotherapy topic, but I believe that it helps our body of knowledge, helps us know how to counsel our patients when certain issues arise, and also helps us to know when to answer questions that are out of our own areas of specialty, or when to refer to persons of other specialty in the healthcare team. So let's begin. In this module, we'll be discussing who should be tested for HIV. We should also be able to define the window period for HIV testing. We should be able to discuss the principles of HIV testing and the performance characteristics of HIV testing methods, as well as the diagnosis of HIV in perinatally exposed infants, which I think is unique and quite different from diagnosis in adults. So moving on to the first item on the objective, which is the question who should be tested. We're going to be considering this question from two different perspectives, both the CDC guidelines and the WHO guidelines. And I'd like to start with the CDC guidelines. The CDC guideline recommends that patients in all healthcare settings be tested for HIV. This would include settings, emergency room. This would include primary care physicians. It would include inpatient care. This will include any outpatient services. It is recommended that patients should be tested in these settings. However, they do offer the opt-out screening testing method. In this case, patients are informed that the HIV test is done as part of routine test, and the patient is given an option of is informed that they have the option of opting out or deferring this testing. In this particular method, you don't require written consent for the testing. You don't require pre-test or post-test counseling. The CDC believes that this helps reduce the stigmatization of HIV and has been shown to increase the number of people who have been tested for HIV. They also recommended that the testing frequency varies based on risk factors, and those patients with high risk factors are to be tested annually, and patients with low risk factors should be tested once and retested with every new potential risk. In areas where you have prevalence of HIV to be less than 0.1%, they recommend risk-based testing, meaning that you test based on exposure. Now, who are patients who are considered to be at high risk by CDC? These are patients who share needles or syringes or other equipment of injecting drugs. Um, the other will be the patients with history of sexually transmitted diseases, or patients who have unprotected sex with multiple or anonymous partners, and patients who have sex with a partner who did not know their own HIV status. For pregnant women, CDC recommends that the HIV test be offered as routine, the routine panel of prenatal screening tests. The opt-out screening method is also employed here, and we do not require separate written consent. And for patients who are in areas where you have a high prevalence of HIV infection among pregnant women, they do recommend that you repeat this testing in the third trimester as well. The WHO has a different emphasis. I guess because of the human rights issues, they will recommend that the testing should be done, but it shouldn't be compulsory or mandatory. They also stress the 5 C's, what they call the 5 C's of HIV testing, which is consent. So unlike the one of which is consent, unlike the CDC, the WHO insists that consent must be given before HIV testing is done. There must be confidentiality, there must be counseling, patients should have a correct test result, there must be connection and linkage to prevention, care, or treatment. The WHO is also emphasizing testing with couples. It should be voluntary, and they should be provided counseling for support with support for mutual disclosure. This should be given to couples and partners anywhere, couples and partners in antenatal care, as well as individuals with known HIV status and their partners. One statement that the WHO made, which I found quite striking, is that the majority of people living in stable relationships are unaware of their partner status, and many people with HIV positive partners are not aware of their own status. Now, this is striking, and I want you to bear this in mind when you talk with, when you counsel patients, when you talk to relatives, and in your dealings with people. The fact that somebody is in a stable relationship may not mean that they are free from HIV. Moving on to the second item, which is definition of the window period. This is the time frame between the HIV exposure and the positive test for HIV. It's dependent on the time taken for seroconversion, which may be up to 3 to 6 months, and a lot of false negative results are obtained in this time frame. I want you to bear in mind that most of the testing we do is test for antibodies. It does take a while before the antibody starts showing up. Now, if you test for antigen, you might get be able to detect antigens in less than a week or 2 weeks. But when you're testing for antibodies, it will take you a longer period of time. Moving on to the different types of HIV testing, we used to use the ELISA. We use the rapid test a lot now, and then the Western blot for confirmatory tests. The time to test, they usually would detect within the first 12 weeks of infection, and that's because they test for antibodies. The rapid test is good because it offers you a result in 10 to 20 minutes, unlike the ELISA and Western blot that might take 2 weeks. The antigen test would detect antigens within 1 to 3 weeks of infection, and can be used during the window period. And this is particularly useful when you're testing infants who are perinatally exposed to HIV. That is because we want to detect the antigen and not the antibody which the infant may have acquired from the mother. So in testing for HIV, we would always require 2 tests to be able to confirm our HIV result. So if we have 2 tests and they agree, either they are reactive or non-reactive, that's a straightforward issue. But when you have one test reading negative and the other reading positive, you will need a third case, a third test to confirm diagnosis. The table shows how to interpret results based on based on the 2 tests that are performed for HIV. It is typically straightforward when you have the 2 tests either non-reactive or reactive. If the 2 tests are non-reactive, of course the patient is HIV negative. If the 2 tests are reactive, of course the patient is HIV positive. But when you have one of the tests reading different from the other, we will need a third test, and that third test, that the HIV status is determined by which of the tests reads reads most. For instance, if 2 of the tests read non-reactive, then we can say the patient is negative. If 2 out of the 3 tests reads reactive, then we'll say the patient is HIV positive. So how accurate are HIV tests? We measure these by the sensitivity or the specificity. The sensitivity is the capacity for a test to identify patients who are infected with HIV. So if the test is the probability that a test will be positive if this patient is positive. And the specificity, on the other hand, is just the ability for this test to identify patients that are HIV negative. So what is the probability that the test is negative if this patient is actually negative? These 2 measures are expressed in percentages, and the next slide will explain to us better how these things are measured. So let us say we have patients we have a group of patients, and their results are put in this table form. You find you have a table that tells you the test results, and the other side tells you what the actual situation with the patients are. So let's say the test is positive, and out of this positive test, you find that A number of patients are HIV infected and B number of patients are HIV uninfected. So your sensitivity will be the probability that in this pool of patients that we are able to correctly identify the ones that are HIV positive, and that will be mathematically stated as A over A plus B. Likewise, the specificity will be indicative of the probability that the test can accurately identify patients that are HIV negative, and so you will be um, quantifying that mathematically by um, C divided by C plus D. The other way to look at the accuracy of HIV test is a positive predictive value, which is usually it narrows it down to the patient in front of you. What is the probability that this patient is positive if the test is positive? And that, if you look at one to express it based on the prior table that we saw, is going to be A divided by A plus C. And that just tells you if this patient is positive, is it really true that this patient is positive? The negative predictive value, on the other hand, is the probability that this patient is negative if the test result that they present is negative. And if you want to think a little bit further, the positive predictive value will be dependent on the prevalence of HIV in that population, and it gives you an idea if you in a highly prevalent environment, you find out the positive predictive value will be high, and in a highly low prevalent area, the PPV will be low, and vice versa. So the testing process usually would you find out that it's important for us that the initial test be optimized for sensitivity. Initial test be optimized to pick out patients who are HIV positive, and then we want the supplemental test to be more optimized for specificity to make sure to make sure that this is a truly positive patient. And so why do we have false positive test result? One of the common reasons will be that the patient has a viral disease or has hematological disorder, or the patient has a liver disease or has immunizations, which will show up as antibodies, which will generate antibodies that may give you a false positive test. Or a patient has autoimmune disorders, or a strange thing called factitious HIV infection, where patients self-report to be HIV infected, but on testing are found to be HIV negative, either because patients report either because they believe they have HIV or they want to mislead the health care system, whatever reason. It's typically based on a false report of HIV by the patient. This is why it is good that when patients are coming to the care and say that they have been diagnosed, that we run our own tests to ensure that this patient indeed is positive. False negative tests would usually happen in acute HIV infection during the window period, may also happen in advanced HIV disease, and sometimes with antiretroviral therapy, where the antibody is so low that it can be detected. You also have a false negative test results with HIV group O, or in situations where it causes seroreversion, which is not very common and happens a lot in infants, where with early treatment patients are able to not show up antibodies for HIV. The other reason why you may have a false negative test result is a poor immunologic response, where patients, either because they have low white blood count like agammaglobulinemia, will show a poor response to HIV, antibody response to HIV, and so this may not be detected by the antibody test. So this slide shows us the WHO recommendation for HIV testing, the algorithm that they drew up for us to use for HIV testing. One of the things that we know with WHO is that we must have pre-test education or counseling and ensure informed consent. Here you go again with the consent. It is important with the WHO guidelines that patients give consent before testing, and then you do the first rapid HIV testing. Now, a negative result with the rapid testing, we assume is negative, and you cancel the patient for a negative result. Now, for a positive result, we do a second HIV confirmatory test, and if the result is positive, we'll cancel for a negative result. In event of a negative result in this situation, you will report the test as inconclusive and repeat after 6 weeks. Take a closer look at the algorithm and see what WHO recommends for testing. So we move on to a patient case about this lady, 30-year-old, HIV infected, has multiparous female, just had a baby, has been taking zidovudine plus lamivudine and nevirapine since the week 12 of her pregnancy. Her current lab shows that she has RNA of 50 and CD4 560. And her labor went well. She delivered vaginally, and she's upset that she has to wait 4 weeks to know if her baby is HIV positive. And how would you explain the situation to her? First, you have to know the peculiarities of infants and HIV. When infants are born of HIV infected mothers, they do store the maternal antibodies for up to 9 months. So if you are testing for the antibody, you might have a false positive test because you will be getting the maternal antibodies. There are also cases of seroreversion, which may take up to the age 24 months, where infants are already are infected, but with early treatment, you find that they revert to not showing the antibodies or the antigen, and this is rare, but occurs a lot in children. There's also the possibility of HIV infection postnatal. So child is not infected perinatal, but due to things like breastfeeding and sometimes sex abuse, you find kids are infected with HIV after they have been born. So this makes diagnosis of infants with HIV quite peculiar and not as straightforward as in adults. The WHO recommends that if a child is born of a HIV infected mother, that we test for do a virologic testing at age 4 to 6 weeks of age, or at the earliest opportunity thereafter. The DHHS, on the other hand, is more aggressive. They want you to do it within 14 to 21 days, repeats after 1 or 2 months, and then after 4 to 6 months. If a child is greater than 18 months of age, the testing should be done same as in a. So the next slide tells us about how to test for infants who are exposed to HIV and who are less than 12 months. Our decision will be based on availability, whether you have a viral test available or if you don't have a viral test available. If you don't have a viral test available, a lot will depend on regular and periodic clinical monitoring, and children, it's advised that children be tested when they reach 9 months of age. For a lot of patients, a lot of clinicians, if there's a high suspicion of HIV infection, we start therapy immediately they are born. Now, if you have viral tests available, our decision will be based on whether the child is being fed or breastfed, and the algorithm is self-explanatory, and if you look closely, you'll be able to understand why and how we should carry on our testing. I'd like to close with this statement from WHO, which I think is quite poignant. The fact that the majority of people living in stable relationships are unaware of their partner status and also are aware of their own status. There is nothing that guarantees somebody in a stable relationship that they know for sure what their status is. This should guide your discussions, guide your counseling, and guide your perception of patients who come into your care. I hope this has been informative. I also hope that you have a successful week on learning with this module. Give me a call or send me an email if you have any questions. Thank you.